this guy's garage. Like and subscribe.
People with opioid addiction living anywhere not immediately local to a bricks and mortar opioid dependency treatment program. All jurisdictions have struggled with this problem. I proposed a new approach that provided virtual care, now expanded to every community in Alberta. To our knowledge, we were the first program to ever look at exclusively virtual care with no in-person component. We collected data on outcomes for our patients, which has been published in the literature. By providing virtual service, we were able to reach people who had never been reached previously. We have served people in 331 different communities, villages, cities, hamlets, all across our geography. Since 2018, we have not had a wait list for services. If you need help today, you get help today. Right now, there are people in Alberta who are certainly calling in for help. Our allied health team starts an assessment. Our physicians work on shift 24 hours per day to assess and treat. Prescriptions go out to pharmacies closest to the patient, including delivery to remote Indigenous communities. Because we use virtual tools, we can also support new places where people with opioid addiction are. Our objective is to reach anyone who needs our care, wherever they may be.
One of the things that I have found is truly revolutionary in the world of addiction treatment is what Alberta's been doing with the virtual opioid dependency program. And I was wondering if you can go into a little bit more detail exactly how it works.
Yes, happy to do that. So the way that it works today in Alberta is, for example, if a person were at home and they were concerned about their opioid use, or maybe they'd ran out of their supply of drugs and they're in withdrawal, they can just call directly to a toll-free number, 1-844-383-7688, and they will get immediately connected with an allied health team member who will start to explore their situation. In Alberta, we have the benefit of a single medical health record, so we're able to see all of that person's health records from their hospital visits, previous overdoses, things like that. And then that person, once they complete that assessment with our allied health team, is almost immediately, it depends on how many people are phoning at one given time, but usually in not less than 15 minutes are connected with an addiction specialist who can then walk through what their treatment options are and then prescribe a pathway forward for them to start evidence-based treatment medications. The prescription is sent to the pharmacy closest to where they live or work as their preference is, and then that person can start right that day with treatment. And our team, of course, will follow up with that person later that day or the next morning, see how they're doing, and we adjust the care from there.
So then what would happen if that person was, say, in a rural community like Janvier and about an hour and a half away from the closest pharmacy? What would happen to someone like that?
Yeah, so that is a challenge. We have many communities in Alberta that are rural remote and that have more challenging access to a pharmacy. So, for example, we're in your riding in a fly-in community. We've been working with the local health teams in that Indigenous community in order to have a supply of medication stored there on site securely so that we can actually send the prescription to that nursing station, and the medications can be provided to that person as needed. Further, we're also working in Alberta to address this problem by enabling our paramedic teams to be able to carry evidence-based treatment medications as part of their kit so that we'd be able to actually connect with our integrated health teams in the EMS world to bring the treatment right to that person.
I think that's truly revolutionary, and I know that required an exemption from Health Canada to even make that possible. Are there any other stopgaps you might have when it comes to Health Canada being in the way of you guys being able to expand this amazing service?
Well, to be honest, we started working with paramedics about 4 years ago. Unfortunately, we discovered that our work was illegal because at that time, paramedics were not allowed to carry Suboxone or Sublocade in their kits. We weren't aware of that, and our paramedics weren't aware of that either. And actually, we were presenting some data on how well it was going when it was brought to our attention that we actually couldn't do what we were doing. Unfortunately, it's taken several years to get the change that's just recently, just in the last couple of months, allowed us to now move forward. And we're looking forward to being able to announce and implement in just a few weeks from now a province-wide program.
Thank you for explaining that. And I think that that just highlights how challenging the bureaucratic mess of Health Canada can be. You did something that is truly revolutionary, getting Suboxone, Sublocade, absolutely evidence-based treatment modalities into communities using innovative solutions, and yet the bureaucracy says that it can't happen, and it took years to get that. So I guess my next question is, can you walk us through what the OPD would look like in Alberta Corrections?
Yeah, so in Alberta Corrections, we of course continue people who are on evidence-based treatment medications after they're arrested. We also will start people on treatment medications. Unfortunately, Canada's largest correctional facility is in Edmonton, the Edmonton Remand Centre, and its average length of stay is about 2 weeks. And what we were finding is that there were a large number of people coming in who were not able to start treatment right away, and the wait time to get treatment was as long as 4 to 5 months. So you can imagine that many people were coming in, were not able to start treatment, and then were released before they had access to treatment, which is a problem. So today, the way that it works is that a person goes in, they're immediately screened for opioid use disorder. They're able to provide a toxicology screen to support that. We do a video recording and connect that with our virtual opioid dependency team, and that person is now able to be assessed and initiated on treatment. I think the average is now 0.9 days from arrival, and we've completely resolved the wait list problem there by using technology.
How is the Alberta Experiment going so far?
Thank you for that question. Alberta is, along with British Columbia, so if we look at the overdose crisis overall and the number of fatalities, British Columbia has the highest rate per 100,000 population. Alberta comes in second, and Ontario is third in Canada. And certainly, the arrival of fentanyl and carfentanil in our jurisdiction does not go unnoted. And none of us are happy with the number of fatalities that are happening because of fentanyl and carfentanil usage. That being said, the reality is that we have an obligation, and so I view my obligation in Alberta Health Services to ensure that we're building the best possible treatment system that we can, that's accessible to people when they need it, so that they can move along the continuum of care and receive evidence-based care. Alberta, I think, unfortunately, part of the story of what's happening in Alberta has not been narrated by Alberta. And so, for example, in Alberta and previously, as I was looking at transcripts for this committee, Alberta does have exactly the same number of supervised consumption sites today as it had 6 or 7 years ago. Alberta recently, just last year, opened 6 narcotic transition service sites that provide hydromorphone by injection or oral under supervision. So those medications cannot leave the site. And those sites are intended to help people with the most extreme form of opioid addiction and the most negative consequences of it. Furthermore, Alberta, as an example, distributed nearly 250,000 naloxone kits last year. So there are a lot of things that are happening in the harm reduction space that don't really make it to the front pages. I wouldn't say that Alberta is not investing in or working on those areas as well. I think where Alberta perhaps is different is that Alberta is trying to implement a recovery-oriented system of care where a person who enters care at a narcotic transitions service site or in a supervised consumption site is encouraged, and there's work done to try and connect that person with treatment supports going forward.
My understanding is that Alberta has about half the number of supervised consumption services. than it did prior to the pandemic. We had the closure of Arches and other supervised consumption sites. I believe my colleague has talked about this closure in Lethbridge, for example. There's also resistance to acknowledging that inhalation as a primary mode now of illegal drug use, that Alberta has resisted this. So perhaps you could talk about when the Minister of Mental Health and Addictions in Alberta talks about strong outcomes for Albertans on the path to recovery. Can you talk about outcomes for Albertans who are maybe not yet on that pathway to recovery?
Yes, I'm not sure that I can speak to outcomes of people who aren't engaged in the health system, in that it's very difficult to measure that. To your comment, there was a supervised consumption site in Lethbridge run by a not-for-profit society that was closed, but the services were immediately transitioned to a site that's under my supervision. It's called an overdose prevention site, so it's not technically a supervised consumption site, but it has booths. It's operated by our public health care system. It's located in the parking lot just outside of the shelter that's in Lethbridge. The shelter, which is operated by the local Indigenous community, actually.
So would you believe that safer supply, and you hear that that information that's being put out there, is the driving cause of deaths, toxic drug deaths in British Columbia, or do you believe that's disinformation?
We know that that's not the case. Now, having said that, diversion is an important issue. It's something we're always watching very closely, but we know from coroner's data that that is not what's killing people in British Columbia.
Do you believe that we should reinstate the expert task force on substance use that Mike Cherry used to co-chair, your colleague?
Yes, I think that would be helpful.